A 22-year-old female was brought to the ER with complaints of alleged history of snake bite at around 10:30 a.m. nearby Pharmacy College. Initial 10-second assessment, patient was conscious and oriented, obey commands. Primary survey, airway, no airway obstruction or respiratory failure or paralysis of pharyngeal muscles. She was able to do single breath count more than 30. Breathing, no breathing difficulty. On auscultation, chest clear with bilateral equal air entry, symmetrical and adequate chest movement. She had respiratory rate of 18 per minute and oxygen saturation of 99% in room air. Circulation, no hypotension or hypertension, no myocardial infarction, cardiac arrest, bradycardia or tachycardia. Disability, good peripheral pulses, pulse rate of 79 per minute and blood pressure of 110/80 millimeter mercury. GC.
Fine, okay. So you have got a young lady who has been brought with an alleged history of snake bite to the ER. So certain questions I wanted to know is that since how long this event has happened, half an hour, 1 hour, 2 hour, that is one question, and whether any first aid was given to her or without any first aid she has come to the ED. So these are the two questions, initial questions that I
half an hour back.
30 minutes back,
30
okay.
Minutes. And no first aid was not given.
First aid, she has not received any first aid. So what are the first aid that is recommended in case of a snake bite? Whether you leave it, whether it is an envenomation, features of envenomation, no features of envenomation, venomous or non-venomous. What are the first aid that you should give? So we'll just concentrate today here on basic first aid and initial stabilization of snake bite. So that's what we are going to discuss. So what are the first aid that we should do?
Ask the patient to
So you can remember the mnemonic, do it right. So that is the mnemonic that you need to remember, do it right. So right means reassure the victim. So what you should reassure her? Telling what you will reassure her. Only thing that you can tell her is that don't worry, we have got a facility where an anti-snake venom can be given. That is one thing. And you can also tell them that all the snake bite might not turn into features of envenomation. So there is a concept called as dry bite, where the venom will not be injected. Even if it is a venomous snake bite, sometimes the venom will not be injected. So, and also you can tell that all snakes are not venomous. So there is a possibility of this thing. So don't need to worry. We have a facility where a polyvalent anti-snake venom or whatever we can be given and make her comfortable. Why that is important? Because reassuring the patient is the most important. If you are not reassuring, with that anxiety itself, the patient can have increasing in the heart rate, increase in circulation, and absorption of the venom can be speeded up. And also, even some patient, after seeing the snake or snake bite itself, they can just collapse and they can have a syncope. That is a very difficult situation to handle. So that is one thing that you need to tell. So you have to reassure her by telling all those things, and you can getting into a facility. Next thing is immobilizing the bitten limb. So immobilizing the bitten limb, there are a lot of myths regarding immobilization of the bitten limb. How to immobilize? Immobilize means you need to put a splint or whatever wooden material, whatever is available, and we should prevent that limb from any further movement. So that is a one thing. And there is no application for tourniquet. Application of tourniquet is not at all recommended. So if at all you wanted to apply something, we can apply something like a soft cloth, or you can apply a crepe bandage, which is recommended, and it should be above the bite side, and it should be tight in a way that you should be able to insert one finger beneath that. So that should be the tight. There is no application of tourniquet. So why no tourniquet? So these are the two questions. One, because you are cutting off the distal vascularity. So that is one thing. Suppose the patient has been traveling for 4 hours from an area, rural areas, to the place where there is an anti-snake venom available. By the time the limb will be totally gangrenous. That is one. And second thing, if you are suddenly releasing the tourniquet, there can be sudden gush of poison venom into the patient's blood, and suddenly the patient can collapse. So rather than the second one, the first one is more important. And the most important thing what you need to remember is that initial spread of the venom is via lymphatics. It is not via venous. So it is via lymphatics. So when you wanted to do, you want to just occlude the lymphatics by applying a crepe bandage. So that is a thing that you need to remember. So do it right, reassure the victim, immobilize the bitten limb, get to hospital. So again, I will be more specific. Get to hospital where there is an anti-snake venom availability. So that is very key. So whenever wherever there is an anti-snake venom availability, you should not take to, there is a primary health center, you should not take there. You should not be wasting your time. So what you should know, or every common people should know, is that which are the nearby hospital where an ASV facility is available. Because giving the ASV is the key treatment in case of a venomous snake bite. So where it is available, you should be taking to the patient to that center. So get to hospital where the ASV facility is available and tell the doctor regarding the signs and symptoms. So grossly, when you say the signs and symptoms, within 30 minutes, the patient will not have any features of envenomation usually. But if amount of venom injected is very much high, they can have, even if it is a neurotoxic envenomation, they can have sudden deterioration. So you need to remember what are the clinical features that you need to consider. So clinical features you can consider into systemic and local. So these are the two things that we need to understand. Whenever the patient's clinical signs can be systemic and local, and in systemic it can be neurotoxic, hemotoxic, or a combination of neurotoxic and hemotoxic, and local examination you need to look in for. So coming to first one, neurological manifestations. So what are the neurological manifestations that you know of?
Paralysis.
See, always remember, it will start affecting the smaller muscles first. So which are the smaller muscles? It are in the eyes. So the patient will start developing, before ptosis, the patient will start complaining diplopia. The smaller muscle, the extraocular muscles will start getting paralyzed. So the patient will start developing, first one, the patient will complain of diplopia. Later on, they can have ptosis. Then they can have bulbar palsy, features of bulbar palsy, then broken neck sign, then lower limb paralysis, diaphragmatic palsy, and all those will follow. So this will be the usual pattern that you need to understand. So that are the neurological manifestations that you need to remember. Sometime in this situation, they will be brought just unconscious. We don't know what exactly has happened. That holds good in case of a crate envenomation, where usually the bite happened during the night time, and usually the bite happened inside the house. So that is the problem with the crate, and problem with the crate, it will not have any local features of envenomation. So there is no fang marks you will be able to identify. So suddenly in early morning, the patient has been brought unconscious, not able to open his eyes. That will be the only history. So in that situation, you need to keep crate bite as one of your differential diagnosis. So that is the other one that you need to remember. That are the neurological symptoms that you need to remember. Now coming to hematological symptoms. So what are the hematological symptoms that you need to see? Bleeding manifestation. So cannot just say bleeding manifestation. It need to be very specific. The starting one, the bleeding at the bite site, subconjunctival hemorrhage, or bleeding from the nostrils. That all will be later manifestation. It will all be initial manifestation. The most simple thing what will get first is that when you are putting an IV line or getting a sample, that area will not get clotted. So that is the first thing that you need to remember. So hemotoxic manifestation, they can have hematuria and all those things very later on. But initial one will be these things. So you have said regarding two systemic manifestation, hematological and neurological, and in Russell's viper, you can have a combination of both neurological and hematoxical. So that is what you need to remember. So neurotoxic, when we say the venoms that will produce neurotoxic is Indian cobra and common crate. When you come to hematological, it will be saw-scaled viper and Russell's viper. When we come into combination, it will be Russell's viper, both neurotoxic and hemotoxic. And problem in crate that you will not get any fang marks. So these are the clinical features. Now we'll go to the local examination. So local examination, the most important thing is to identification of a fang mark. Fang marks are basically two dots separated around 0.5 centimeter apart. But in all cases, we cannot assure that there will be a fang mark. And by seeing a fang mark also, you cannot say it is a venomous or non-venomous. So fang mark is only thing that somebody has bitten the patient there. That's the only clue that you are going to get. So what are the examination that you need to? Pain at the bite site. So that will be the most common one. Even pain at the bite site can be seen in a non-venomous snake bite also. So pain at the bite site. Next thing is swelling. Rapidly increasing swelling. Swelling will be there for any bite, but rapidly increasing swelling. That is again a clue that this patient has got a venomous snake bite. Then there can be bullae formation. There can be blisters, bullae formation. That is very common with cobra. species. So that gives again you clue for an possible venomous snake bite. Next, most important one, as I told, the initial spread is via lymphatic, localized lymphadenopathy. So you need to look for, if it is in the lower limb, you need to look for popliteal or inguinal lymphadenopathy. So that will be the earliest feature, one of the earliest feature. If you are finding these things, then definitely that patient has got significant envenomation and that patient should receive an anti-snake venom. So the situation is that this lady had come to the ER and she has not received any first aid. So do you want to do any first aid at this point of time? No, she is already in the hospital. So there is no point in obstruction and all those things is not needed. You can just see the patient and do the history properly. Then, as you said, examination the patient. So examination, you started the normal examination, and the most additional investigation that we need to do is a single breath count. Single breath count is basically you are asking the patient to hold a breath deeply and ask her to count from 1 to 30. Usually we'll be able to do 1 to 30. Rather than a single SBC, we need to see serial single breath count. So now it is 30, later on it is 20, now it is 15, that is significant. So if it is 30, 30, 30 holding on, it is good. So if it is coming down, that is significant. So that is the next thing that you need to look in for. So that is the additional parameter that you need to look in for. The most important thing, you have to be with the patient. So be with the patient, you look for the subtle signs. They will have initially, whenever there is a features of envenomation, abdominal pain and vomiting. Reason behind this is still unknown, because most commonly with crate envenomation, they can have this abdominal pain and vomiting. There is some sympathetic overactivity. There has been a lot of theory behind this, but still it is not very clear why this patient is having an abdominal pain or vomiting. So this patient had come, she has not received any first aid, she has come to your ED, you have done a local examination. What was your local examination finding? Anything you got in the local examination? Any fang marks you were able to identify?
There is a single bite mark.
Single dot you were able to identify with minimal bleeding manifestation that might be due to any of the bite. So she didn't have any of these things. And how important it is snake identification in case of a snake bite. You wanted the patient or the bystander to bring the snake to the hospital. It's not at all needed. Our treatment is solely dependent upon the clinical manifestation. So if somebody is coming and telling you have been bitten by cobra, you don't have any clinical manifestation, we will not give anti-snake venom. Somebody is telling I have been bitten by a rat snake, but he has got clinical features, we need to treat. So that is, identification of snake is of least importance. Our treatment in the hospital is solely dependent upon the
Symptoms.
Clinical features by which the patient present. As I told, the spectrum of presentation we have already discussed. Now this patient is in your ER. I am telling this patient in an ER of a super specialty hospital, and the same patient can be in a peripheral hospital also. So in a super specialty hospital like this, 20 minutes WBCT. So that is what WHO say. You have to do 20 minutes WBCT. So 20 minutes WBCT can be done in any center. But when you have a facility for other things, PTANR and APTT is much better investigation. Why? So first one, 20 minutes WBCT. It is easily available. It can be done by any person. So that is one. There is no cost involved in doing a 20 minutes WBCT. PTANR, it is costly and all centers is not available. But the problem is that for 20 minutes WBCT to get prolonged, it will need at least your 30 to 40% of your coagulation factors to get deranged. So detect an early coagulopathy, 20 minutes WBCT will not help. But in a peripheral center where you don't have anything else, you can do a 20 minutes WBCT. But in a facility where you have got PTANR, not point of care PTANR, that is again, it is not found to be effective in snake envenomation. There has been a lot of studies. You are going to send a lab PTANR. When you follow up, you can get within 20 to 30 minutes. By the time you are getting doing a 20 minutes WBCT, you can get a lab PTANR report. So PTANR will start getting elevated. Even 10% of your clotting factors are deranged. So that is very important. So that is the next thing that you need to remember. So these are the two things that you need to consider. Again, WBCT, the problem is that you need to have a clean glass container. So majority of the time we will be preparing during that time. Again, there can be falsely positive WBCT also. So one investigation that you need to do is a coagulation profile. Then the most important investigation will be a platelet count. then renal dysfunction is there or not, and maybe an ECG to look for any features of myocarditis or anything. So these are the basic investigations that is needed at this point of time, and you need to closely monitor the patient. So the rule is that any alleged unknown bite, even if it is a snake or an unknown bite, you keep the patient under observation for a minimum time frame of 24 hours. So if at all any manifestation is going to happen, it will happen within 24 hours. But there are case reports where the manifestation has happened beyond 48 hours also. But in general recommendation, you keep it at least for observation for 24 hours. Then you see the patient, and depending upon the indications for anti-snake venom, you administer the anti-snake venom. So indications mean you need to have either systemic, or you should have any features of local attenuation, or you should have laboratory abnormality to give your anti-snake venom. So when you decide to administer anti-snake venom, you need to mention that how much ml each of these things that we have already discussed a number of times. So I am not going into detail. So what I want to do to concentrate here will be the initial management and doing a proper first aid for a snake bite patient. So that is what we need to understand. And this patient never had any features of envenomation. She never had any of these things. Her serial PTNR was monitored and it was found to be normal, and she has been discharged. So now the question comes, how frequently you should check PTNR? So there are no recommendation as it how frequently you should check PTNR. So what you can in a nutshell, you need to remember that 4 to 6 hours interval should be enough. Maybe the initial, maybe you can little bit, maybe in the first 12 hours, you can maybe go to 3 hours once in 3 hours. But routinely, a 4 to 6 hours PTNR should be good. Because we cannot predict when the patient is going to develop a coagulopathy. Once within 12 hours she is not developing, she is unlikely to develop within the next 12 to 24 hours. So these are the things that you need to remember. And there are certain mandatory things that you need to do for any snake envenomation, whether it's a venomous or non-venomous. One is tetanus prophylaxis, and you can give a antibiotic, basic antibiotic, amoxicillin, doxycycline, any of these things to prevent a local cellulitis. So there are some species of snake, they will not cause any systemic manifestation, but they will cause significant cellulitis. So there are specifically in areas of in hilly regions and all, there are very common in Munnar and all. They will not cause any systemic manifestation, but they will have local irritation and a lot of pain and cellulitis. So that part we need to take into consideration. And you need to remember, whatever antivenom available, it is a polyvalent anti-snake venom. It will cover only 4 snakes. So which are Indian cobra, common krait, then Russell's viper and soft-scale viper. It will not cover hump-nose spit viper, which is nowadays very common in Malabar region and all those things. So this is in a nutshell. The take-home message is that you have to do a proper first aid, proper assessment. What are the investigation, even if it is a venomous or a non-venomous bite, these are the things that you need to follow. And depending upon the features of envenomation, you decide for your anti-snake venom and you treat accordingly. Okay, fine. Thank you.